year. And I'll give you just a chief complaint. This was a 20-year-old male who presented his excessive sleepiness for 9 months.
Thank you, Joseph. So I'm not sure, but I think it's been, if not once, twice, we've discussed about excessive sleepiness here. So a 20 years old male who presented with excessive sleepiness for 9 months. There's a number of things that come to mind. Uh, excessive sleepiness, I'll definitely. So the first thing that I'll need to hear is get more qualification of this excessive sleepiness, including the timing, how it interferes with activities, because there are people who will take a nap in class. There are people who will take a nap even when they are talking. So those low stimulation activities, like reading a paper, or someone is watching TV and then they fall asleep. So I think I need a number of details, but overall, when I hear excessive sleepiness, in addition to the qualifications that I'll need, I think about a number of things. So to start with, uh, there are primary disorders. So like uh, narcolepsy, I think there's type 1 and type 2. And then, yeah, I remember we had a case that we discussed here, and I thought it was narcolepsy, and then we ended with a diagnosis of Klein-Levin syndrome. So those are primary disorders of sleep. But then, so others will be more secondary. Someone who has obstructive sleep apnea, uh, so they are not having quality sleep in the night, so they doze off a lot in the morning, during the day. But then there are drugs that can cause excessive sleepiness. There are endocrine abnormalities that can cause excessive sleepiness, and then of course there are infections. Although I should say that for me, it's just been reading them in textbooks. I do not remember in my life taking care of a patient and then suspecting something like trypanosomiasis, so sleeping sickness. But the infections that can present with excessive sleepiness. So I think that is very worthy to start with. But so those are the big buckets that I'll be thinking about when I try to solve this case. So let's hear the HPI.
That's a good start. So his mother reported that unless he wakes this boy up, he would to eat breakfast, he would sleep the whole day, and he doesn't want to do anything apart from sleeping. He falls asleep in between conversation, and then this is associated with excessive water intake and urinary frequency. The patient reported that he had this thirst which never goes away, but denied polyphagia. The family that was there when I was taking the history reported that the patient seems not to be like himself over these 9 months. They have observed the episode of memory loss at one point. He didn't remember where the toilet is, and then he would forget some details. He dropped from college because performance kept dropped, and then he had to quit the college. He doesn't want to shower or brush teeth, just want to sleep. But he denies sudden muscle weakness or sense of paralysis when waking up or falling asleep. He denies snoring at night, auditory or visual hallucinations, aggressiveness, suicidal ideation, headache, double bloody vision, fever, focal neurological weakness, seizure, or weight loss. And there is no known use of any substance. Behavioral system, unremarkable. Past medical history, non-contributory. But in the course of this illness, so he was studying in Europe, engineering, and the disease started there. And the story is he was admitted in psychiatric ward there, was given some medications, no improvement, and they agreed that he has to be brought back to home. And that's why he came to me. Yeah, that's it.
Yeah, It's unfortunate for the patient. Interesting presentation. Uh, so excessive sleepiness. So basically, the patient, if not, if the mother doesn't wake him up, he sleep the whole day. So I'm trying to pick some things here. He doesn't want to do anything apart from sleeping. And then, like I was saying, low stimulation activities like conversation, the patient falls asleep in between them. Now, the next bullet is something that had me thinking. So, excessive water intake and urinary frequency, and he reports a thirst that never goes away. So, I think I need to spend some time and discuss this. So, when someone is taking a lot of water, and he reports thirst. So excessive thirst, of course, when we hear increase the frequency of urination and then thirst, we think of diabetes. Whether diabetes mellitus, where someone has hyperglycemia, uh, or diabetes insipidus, where someone is, there are issues with the antidiuretic hormone, and therefore someone is peeing a lot, and therefore they have to take in a lot of fluid. So diabetes. But then with diabetes mellitus, we see the other characteristic lacking, which is polyphagia. So yes, the patient drinks a lot of fluid, has a lot of thirst, and then but he's not eating a lot, and we have not had, because review of systems was unremarkable. So I believe also there are no weight changes, especially weight loss, which will come with diabetes mellitus, with hyperglycemia, which has been there for a while. So diabetes mellitus, we cannot completely throw it out, but I think the likelihood is low because of the other missing pieces. Although now when we come to investigating this patient, it's also important to do a blood glucose and maybe glycated hemoglobin just to see what is going on. So the other thing is the other thing is that the patient, so the first I talked about diabetes insipidus. Uh, so well, that could be a possibility, but the other possibilities, like why is this patient taking in a lot of fluids? So if someone is drinking a lot, another thing could be, so there's primary polydipsia, where someone is just taking in a lot of fluids. But I believe in this, the patient would not report that thirst that is not disappearing. So could this be related to the excessive sleepiness? Well, theoretically speaking, could be. If someone, let's say they are taking in a lot of fluid, we do not know what they lose when they go to pee. If they are losing fluid plus electrolytes, and therefore they have hyponatremia, they could be sleeping a lot. Hyponatremia can cause drowsiness. So that could be a possibility. So I'm thinking, is this signal? So is it the cause of his excessive sleepiness, or is it just part of a multi-systemic presentation? We'll see. So the other thing is that we see some we see some cognitive symptoms like memory loss, also forgetting the location of the toilet, and then some other details. So something else that comes to mind here is we need to make sure that we rule out a mood disorder, particularly major depressive disorder, because major depressive disorder can present with insomnia or excessive sleepiness. This patient does not want to do things including self-care, like taking a shower, brushing teeth, uh, and then the dropping performance at college, and even memory loss. These are things that can come with major depressive disorder. So although I remember in the next slides you talked about the patient has no suicidal ideation, but I've not been attending patients with these issues for a while, but so there are those specific questions that I'll need to ask the patient. Are there feelings of worthlessness, excessive sadness, and other details that will help me establish if the patient is depressed. Because depression, I think, can come with these, although there are these other features that are not in keeping with that, particularly the issue of excessive thirst, taking in a lot of fluids. So that bullet, that it denies a sudden muscle weakness. I talked about the primary sleep disorders like narcolepsy and then Klein-Levin syndrome, which can come with these. So uh, uh, it's cataplexy. I think that's what it's called, cataplexy. So patients with narcolepsy, when they have intense emotions, whether it's happiness or sadness, like when they laugh, they lose muscle tone and therefore they can collapse. Uh, Sleep paralysis. So sleep paralysis when waking up or falling asleep. These are associated disorders that can come with those, narcolepsy particularly. So snoring, I talked about obstructive sleep apnea, doesn't seem to be the case. So hallucinations can come with the primary sleep disorders, but then those are hallucinations are the hypnagogic and hypnopompic hallucinations, which happen only when the patient is waking up or falling asleep. So the other hallucinations, you'll see them in schizoaffective disorders. So someone can have a mixture of schizophrenia, for example, and now I think I'm loosely using terms here, but schizoaffective disorders can come with hallucinations. So no aggressiveness, suicidal ideation, and then symptoms that would be indicative of a structural lesion, for example, in the CNS. So like headaches, features of increased intracranial pressure are missing in this patient. Features of uh, intracranial inflammation going on, or systemic inflammation like fever. So these are missing. And then very important, use of substances, because we know opioids sedate people. So people use opioids, whether injectable like heroin, or there are opioids which are used as medications, but people can abuse them, and these cause people to be very sleepy. So all these are missing in this patient. Let me see, the review of systems I think was unremarkable. Yeah, so no cough, shortness of breath. So basically, past medical history non-contributory. So these are important. I talked about some medications. So opioids themselves, benzodiazepines, and then gabapentin, pregabalin. These are medications that can sedate people and cause excessive sleepiness. And of course, even antidepressants like tricyclic antidepressants, amitriptyline, and others, they can cause people to be excessively sleepy. So this patient is not using any prescription medications or drugs of abuse. Then there are endocrine abnormalities like hypothyroidism, particularly. We have not had any symptoms which are in keeping with hypothyroidism. So uh, I think there's still a lot to untangle in this patient. But so far, a 20 years old male presenting with excessive sleepiness for 9 months. And then a notable symptom that we saw is that the patient is experiencing excessive thirst, and therefore he takes in a lot of fluids. He and there are some cognitive slash, yes, I should say mostly cognitive, like memory loss. And then I'm still struggling to classify the other, that the patient is not properly taking care of himself, including taking showers or brushing teeth. But otherwise, no symptom suggestive of increased intracranial pressure, space occupying lesion, at least what is apparent from the patient has no focal neurological deficits, no features of increased intracranial pressure. So I think there's still a number of things that I need to pick apart, but let's hear the exam if there's anything significant.
Yeah, that's impressive. So here's the exam. When I saw the patient in the office, he was alert and oriented. He wasn't in any stress. He was a febrile, not pain, not jaundice. Didn't have any lymphadenopathy, no lower lymphedema. So he was drifting in and out of sleep multiple times when I was taking the history. Vital signs is somewhat labile blood pressure of 86/60, a normal pulse rate in the respiratory rate, temperature sat normal. Neuro exam, he was alerted related to people, place, person, and time. He couldn't perform CTO7 backwards, and he also had impaired short-term memory. When I asked him what he took for breakfast, he forgot. And when I told him to remember something, he couldn't. But he had intact long-term memory. He remembered what he was studying in Europe, which country he was, when he was born, stuff like that. His language was fluent. His cranial nerve were normal. He didn't have a pronator drift. Motor exam was normal. Coordination was also, he was uncooperative, so I couldn't perform it because the attention, he didn't have an attention to understand what I was talking about. But he had a normal gait. Abdomen, respiratory system, and cardiovascular were all normal.
Yeah, so the patient has excessive sleepiness, and so we pick that even during exam. Now, in the vitals, the diastolic blood pressure is at the line. So the diastolic blood pressure is not supposed to drop below 60, but the systolic blood pressure is low. The cutoff is 90. So does this tell us something? Could be, although maybe not very much. Cardiovascular system exam was unremarkable, but then so someone who has a low or a reduced effective circulating volume due to anything, dehydration, due to excessive diarrhea, vomiting, or they are losing in a lot of fluid by peeing, whether it's because of diuretics or anything else, can present this way. So based on his history, I'm interested to know, though, of course, on examination, Joseph did not tell us if this patient looks dehydrated, maybe having dry mucous membranes. So hearing that cardiovascular system examination was unremarkable, so the assumption that I make is even capri fill was normal. The temperature of the extremities was normal. So, but I'm thinking now particularly sodium and water because of his borderline blood pressures. And then, so neurological examination, impaired short-term memory, and then of course we pick that the patient has impaired, I should say, attention and concentration because the patient cannot perform Serial 7. By the way, I'll need to go back and so it mental status examination when you do Serial 7, which are you testing particularly? So between the two that I just mentioned, but I think the patient has impaired concentration particularly, maybe because of the sleepiness or because of something else, but we also see that the patient has impaired short-term memory. So does this localize? Does this localize anywhere? We do not see. So the rest of the examination is unremarkable. So does this localize and tell me where the issue is? I think because of my limitations, I'm struggling. But then I'll try and represent the problem. We are discussing a 20 years old male who has an unremarkable past medical history. He presented with excessive sleepiness for 9 months, excessive thirst, and polydipsia. Memory loss because he forgets even the location of the toilet, and then he's not taking care of himself. On physical examination, we see a borderline blood pressure and then impaired short-term memory as well as concentration/attention. Yeah, so I think my thoughts are still the same. So Joseph, what of course I think so based on what we are hearing, I think there is something organic that is going on. Something organic meaning it's a pathology. There is a specific pathology that is causing all this presentation. But then just to be sure, I think what I would do for this patient, is I would also make sure that I run a depression screen. So the questions that I talked about earlier, issues about extreme sadness, because I do not remember you mentioning it, Joseph. If the patient has feelings of worthlessness, uh, loss of pleasure in, because we are told the patient only wants sleeping, so he's not even taking care of himself. So has the patient lost interest in previously pleasurable activities? So I would just do that. But then, as I said, I think it's something organic. It's something organic. So, uh, and what is that something organic that I'm talking about? Excessive sleepiness, and then the excessive thirst, and the polyphagia. I mean the polydipsia, not polyphagia, that the patient has. I have a number of, I haven't been able to make much progress, but I think at this point, what I'm thinking of, number one, as I said, diabetes is something that I cannot rule out, not diabetes mellitus, but insipidus. Although I'll tell you that it's been a while since I read about diabetes insipidus, but I do not remember coming across this dramatic presentation. So with diabetes insipidus, it can be nephrogenic or it can be central. So nephrogenic, so central is when because control volume. So the control of urination, whether you need to urinate more when there is excessive fluid, or to urinate less in order to save fluid as well as electrolytes, that is something that is under control of a number of systems, but one of them is the antidiuretic hormone, which is the antidiuretic hormone is synthesized in the hypothalamus, but then it's just a conduit in the posterior pituitary, but then in the hypothalamus. So I'm thinking, could this be the issue? That's why the patient is peeing a lot. So it can be any of the two, whether it's central or nephrogenic. So in nephrogenic, the patient is unresponsive to vasopressin. So the receptors, or due to any other issues, it's unresponsive. So antidiuretic hormone is produced as usual, secreted as usual, but then the kidneys are not responsive, or central, as I said earlier. So that would explain the urinary frequency or the polyuria, and it could also explain the polydipsia, because the patient is trying to compensate, and then the resulting the resulting electrolyte abnormalities, is particularly sodium, could explain the changes, particularly the sleepiness. Of course, I do know that uh, far-fetched electrolyte abnormalities can also explain some cognitive symptoms, including concentration, including memory. So that is one of the things that I'm thinking about. But apart from that, I think the primary disorders of sleep that I talked about earlier, less likely because of the absent associated symptoms, but I think we still need to keep them close. So I'll go ahead and investigate this patient, although I think there are serious gaps in my knowledge. So I'll need to go back and read in order to see if really diabetes insipidus can present with this dramatic presentation. But I'll definitely need to see electrolytes in this patient. And yes, just to be sure, glucose and glycated hemoglobin, if it's not too much for the patient, plus other investigations, and then I can make progress from there. So back to you, Joseph.
Okay, thank you very much. And let's see the progress. So here are the labs. He had a normal CBC, ESR raised by 60, RBG was normal, MRT HIV negative, electrolytes were within normal limits, and renal function tests were normal, the TSH was normal. His urinalysis was normal with specific gravity of 1.020. Yeah, this ends.
Wow, this is a tough one. So let me run through this lab. So the CBC is unremarkable. ESR. So an elevated ESR. I think I'll leave this last. So RBG normal. I wanted to do that because yes, polyuria. The patient presented reported excessive thirst, polydipsia, but then I had my reservations from the beginning. So that is unremarkable. And then yes, I think infectious etiology is important to think about. So particularly HIV and remarkable. So the electrolytes that I wanted to see so bad, turns out they are all normal. And then even renal function test and yes, a urinalysis. So I think I'll spend some time and dwell on the urinalysis before I go back to the before I go back to the ESR, and then before I do that, just talk about the TSH, that it is normal. So we rule out thyroid pathology. I talked about hypothyroidism as a possible explanation of excessive sleepiness. So a normal TSH rules out hypothyroidism or hyperthyroidism, although hypo is more appropriate here. So urinalysis. So someone who is losing fluid, someone who is losing a lot of fluid, we could see. So if there are some abnormalities, we could pick some from the urine. If it's excessively diluted, which means the patient is excreting a lot of free water without a lot of electrolytes, the specific gravity would be low. So a normal specific gravity or specific gravity within normal limits tells us that the patient's urine is normally concentrated. And of course, if it was a lot of electrolytes which are secreted with a small amount of fluid, the specific gravity would be increased. So uh, even if the patient is having a lot of producing a lot of urine, but this urine is properly concentrated, which means even if the volume is increased, it's likely that the electrolyte concentration of that urine is optimal. And that's why the specific gravity is normal, and then we did not hear any other abnormalities in the urinalysis. So that is what I pick. But then I would need to go and check because so I think this is desperate that this is a desperate measure, but I think I'll need to go back and check now that with the pathologies or the differentials that I'm considering, um, is it possible that this person could be having diabetes insipidus, for example, or I think something else that I wasn't talking about, although with normal electrolytes, I'm also struggling to think about is cerebral salt wasting syndrome. So cerebral salt wasting syndrome is so what I remember, because I do not have a lot of details with me right now, because I haven't read about it in details. You will commonly see that in patients who have an intracranial process that is ongoing, whether it's a traumatic brain injury with increased intracranial pressure, whether it's a CNS infection, or anything else that is affecting the central nervous system. They can present with salt wasting syndrome. So if it's salt wasting syndrome, then I would expect the abnormalities that I just talked about in the urinalysis. So whether it's DI, whether it's cerebral salt wasting syndrome, I'm struggling to recall if they can present with a normal urinalysis. Uh, so those are my thoughts about the urinalysis particularly and the normal electrolytes. Now let me go back to the ESR. So the ESR is elevated. So ESR, the way we commonly think about it is ESR is an inflammatory marker, is a marker of inflammation. So could this patient be having an inflammatory process that is going on that is causing this presentation? So I'll say for this patient, I'm struggling to recognize any particular pattern, but then let's try. So and I think the next thing that I'll need to learn is what else can cause an elevation in ESR if it's not an inflammatory process, because it's important to know the limitations of the different tests that we do. So maybe Joseph, if this doesn't turn out to be an inflammatory process, if you have that information with you, maybe you can reinforce that information in us. What are other things that can present with an elevation in ESR apart from inflammation? But this patient having a normal CBC with a normal hemoglobin, so we cannot talk about things like anemia and others leading to so hemoglobin abnormalities leading to this uh, abnormality that is observed in the patient. So inflammatory conditions, infections, and then autoimmune, and then malignancies. So out of infections, I do not know an infection that can present, because if we talk of infections, I would say an infection that is playing out, for this long duration, uh, that is a subacute to chronic infection. So you have to think about something indolent. So ruling out the usual bacterial pathologies, and of course we did not pick any fevers. I do not remember hearing, of course there was no headache, but issues like neck stiffness, I do not remember hearing those. So if we talk of infections, I would say it should be something from subacute to chronic, like a viral infection. And when you talk of viral infections, you have issues like that can cause encephalitis. You have issues like herpes simplex and other infections. So most of others that I can think about are infections that we'll commonly see in immunocompromised patients. So a common cause of immunosuppression in our setting, HIV. Another one, diabetes. So both of which have been technically ruled out in this patient. So maybe this patient is not immunocompromised. So, but viral infection, so a viral encephalitis. But but that one, so maybe let's entertain that possibility for a while, and then others are like tuberculous meningitis and cryptococcal meningitis, which again, uh, at least some of the common causes of immunosuppression we've ruled out in our patient. So we have to think about some other things. So I think that is for infections. I'm struggling to see an infection that is that can explain this patient's presentation. So uh, another one is autoimmune conditions. So this is a young male. Autoimmune diseases, most of the ones that we commonly think about, we see them in females, although that does not mean they do not happen in males. But then I do not know an autoimmune or immune mediated condition that will just present with excessive sleepiness and then excessive thirst and increase the frequency of urination, not affecting other things. So I'm struggling to find any. And then lastly, uh, malignancy. So this is a young patient, of course, not exempted from having malignancies. But then what I'll say is, so for this patient, I'll need to do one thing: do imaging. So I'll need to do brain imaging in order to see if there is any process that we can pick. But otherwise, so Joseph, I think I'm struggling to make a diagnosis here. So I'll just mention a number of possibilities. Uh, although with the discussion on the urinalysis and the electrolytes, I think I will still keep this. So if I was attending this patient, I think I'll do those other investigations and then consult some other people, but then I'll definitely go home and do some reading in order to see if diabetes insipidus or salt wasting syndrome are in keeping with the patient's presentation. So particularly when I mention salt wasting syndrome, it does not ring a bell because the patient has normal electrolytes. But I'll try to see if those fit the patient's presentation. But then I'm thinking uh, there could be an intracranial process that is ongoing, and therefore I need to do imaging. So those are my thoughts for now. But then uh, telling now that with elevated ESR, what could that be? So infections, I'm struggling to establish any infections, and I'm also struggling. Should I do a lumbar puncture in this patient? I think I would keep that pending and do imaging first. And then once I do imaging and it's non-revealing, I think I would think about doing that. Although this is a desperate measure, because I'm thinking I mentioned some subacute to chronic infections that that could explain his presentation, although they do not explain everything. So imaging. And with imaging, I need to see if there is a mass somewhere. And yes, I'm getting some help here. So I think it's time to check the chart. Uh, yeah, so hypothalamic pituitary lesion, uh, having the same thoughts. Yeah, so uh, could this be could this be that the mass is somewhere where it's interfering with wakefulness? Yes, I think that is something that I did not discuss initially, but something that I did not discuss initially about that a lesion happening somewhere that it interferes with wakefulness. So, for someone to be awake, the reticular activating system has to be working. So when you talk of the reticular activating system, And yeah, I think my neurology is not perfect, but then that is not found in the cerebral cortex. So you are talking of the brainstem, the pons and the brainstem. And so Petro here has something. So which has hypocretin neurons, a center which promotes wakefulness. Further tests needed with that. So yeah, the sodium was normal. Okay, so checking copeptin and then doing water deprivation test. I'm not sure if this is something that is still recommended. I remember reading some literature that it's something that is not currently indicated. So diabetes insipidus is something I'm thinking about. Primary polydipsia, I was thinking about it, but then primary polydipsia, I'm thinking this patient is having excessive thirst. So primary polydipsia, is it someone just having the urge to drink a lot of fluids even if they do not feel thirsty? But then with the primary polydipsia, would we also expect to see dilution or hyponatremia? I'm not sure. So I think Joseph will teach us about this. So yes, so the hypothalamic pituitary axis are still having the same thoughts, and then a thalamus. So a thalamus, we are talking about the pituitary, but then a problem could be right from the hypothalamus. So trypanosomiasis, I'm not thinking about it in this patient because so first of all, this patient was abroad, and so the presentation I think started right from when the patient was abroad, and in Europe those are not tropical countries, and therefore it's likely that they do not have the tsetse flies that because those are found more in the tropics to infected tsetse flies biting someone and then infecting them with the trypanosoma. So I'm thinking that is not likely in this patient. Yeah, so Joseph, this is a tough one. Those are my thoughts. I'm thinking there could be an intracranial process which necessitates to do imaging, whether that is located in the hypothalamus, causing central diabetes insipidus. That is one thought that I have. And then, of course, with the other differentials, which are very low on the list, like infections, we can pick like leptomeningeal enhancement or changes in the brain parenchyma itself, if it's an encephalitis, although not very supported in this patient. So those are the thoughts that I have. And not to forget, so long the list, as I said, I will need to take a detailed history just to rule out mood disorders in this patient, although they do not explain everything, because a major depressive disorder will definitely not present with an elevated ESR. So those are my thoughts for now. So if you have any other investigations before that I can discuss before the final diagnosis, but those are my thoughts. But overall, I think very difficult to get the diagnosis in this patient for me. Back to you, Joseph.
Thank you very much, David. I think you're in the right track, and I'm glad that if you would have seen this patient or anyone in the chat, like Florence or Moshi or Roland, the patient could have benefited. It's a sad story. It's these 9 months you're seeing, the patient came back like 2-3 months after illness when he was admitted in Europe in psychiatry ward. And then the family, who is a well-to-do family, realized, okay, he was in Europe. I think it's a psychiatric illness, and they just sat with the patient at home. until that I saw them. So I believe anyone who could have seen this could have had a better care than what they did in Europe. And yeah, so you are right. The imaging is the thing here. And I also ordered an MRI, and it came out saying there's a peripheral enhancing complex cystic and solid supracellular mass 4 by 3.7 centimeter, which was attached to the pituitary stalk. But the pituitary gland was seen separately, not involved, and there was no paracellular extension, no optic chiasm compression. That's why I was seeing normal. So it's an intriguing case, and it's just even if you didn't know the diagnosis, as you are saying here, you knew some other things, but you're saying, okay, they're not making sense. This is not uh, a central sleep issues that we presented multiple times here. Is something organic, which is that's enough. That's the clinical reasoning for this case. So I sent this patient to neurosurgery who put a VP shunt, and there was much improvement, although some things stayed, like sleepiness was still there, but a little bit, much improvement. And then memory loss was not much. And then he was planned for surgery to remove the tumor. So I present this again. I presented the other day that we had the case of hypersomnia, and I saw the patient. I looked at it to see, am I missing any other thing of hypersomnia? Then I realized I've labeled there, you can have neuro disorders like neurodegenerative disorders, multiple sclerosis, ALS, a lesion in the thalamus or hypothalamus or brainstem, or a stroke that you can present with this. That's why we opted to do imaging. So here's the imaging, as you can see. So they're saying the tumor is around this place in the stalk. And the stalk is a communication between hypothalamus and the pituitary. And it can affect anything that is involved in the hypothalamus and the pituitary at all, as we will see. So if it stays there, it can compress, but luckily they told us it's not compressing the pituitary, but it must be compressing maybe the hypothalamus, or even just impairment with the transmission from the hypothalamus to the pituitary. That's why we are seeing these symptoms in this patient. So I looked at it to see any relationship with brain tumors and hypersomnia, and it's well documented that if you have a damage to work promoting system, as someone is saying in the chat there, and these are hypothalamus and midbrain, you can have hypersomnia. But also, if you have secondary hydrocephalus or raised ICP, we result into bilateral dysfunction of the cortex and midline structures that can also cause hypersomnia. So if there are accompanying symptoms, they will tell you maybe what is the localization. Like if you have pituitary dysfunction, like in this patient, truly, what I also thought, this must be central DI. I didn't pursue it because very unnecessary, straightforward. And abnormal movement, or if you have hemiparesis, it can tell you maybe the tumor is sitting on one part of the brain or not. So I think what made maybe the doctors initially not to think that this is a CNS thing and we have to image, maybe the issue of headache. And also when I asked the patient, told me no headache. I wonder why should I have no headache. So also I wanted to understand this. So headache is very interesting in tumor pathology. So it depends on the speed of growth of tumor. If tumors grow very slowly, you end up not having headache at the end. If you have a rapid growing tumor, you can have headache even if the tumor is small. So think of this like 9 months and the tumor is 4-3 centimeters. The slowly growing tumor is the reason. But again, if you have a tumor which obstructs CSF flow, that will definitely cause headache. If it doesn't, maybe not. And the size and the mass effect of the tumor also matters. But location, usually supracellular tumors will present more with endocrine behavioral symptoms before the pressure symptoms. So maybe pressure symptoms comes very late. And something else, if we want to localize your neurology, you have to localize the symptoms. The polyuria can be explained by the ADH pathway interruption on the pituitary stroke, causing central diabetes insipidus. The hypersomnolence is because of the hypothalamic arousal networks also affected. And the memory loss, there are also connection between the hypothalamus and limbic connection, and limbic is involved with the memory. But again, if you have an inattention, you cannot form new memories. Like I tell you, you have to remember these numbers, and then you are inattentive, then you can't form new memories. That's why even other research say if you see a patient in examination, you do attention and they don't have attention, it means the further neuro exam is not reliable because that patient is not attentive. So yeah, the DGX of that tumor, I just try to look. First one that I think is highly probable is a craniopharyngioma, which is common in Africa. It has a bimodal distribution, and it can be solid or mixed, solid cystic like this one. And usually it arises along the stalk. So I think highly likely it can be a craniopharyngioma, but the usual diagnosis is an intracranial germ cell tumor because of the age of the patient, and more common in young male like him than females. And the most common also location this is suprasellar pineal gland, and but this is usually solid. So yeah, any can be the one. So that was the case today. I think David, nice discussion, and everyone in the chat. That's pretty cool points. Thank you very much.
Thank you, Joseph. So first of all, yeah, it's a sad story for the patient that he had to suffer all those months uh, without having a diagnosis, and then initially diagnosed with a psychiatric illness and ending up in the psych ward. And so that's a sad story for the patient. Very sorry for the patient. But next, to congratulate you because you did a good job. So I think this beats the stereotypes. This beats the stereotypes that you know it's common that when people, especially people who are well off, they when they have issues which are ambiguous and people do not know what is going on, what do? They will seek attention in settings which they think are more advanced, and yeah, because they believe maybe people are more competent, then the infrastructure is very well developed, and therefore they are likely to get solutions for their problems. But then this case reminds us one thing, that the practice of medicine remains the same wherever you are. Yes, it does not this does not undermine the structural issues that we face in the developing world about not so properly developed infrastructure, but then the art of medicine remains the same. You pay attention, you will help someone. So I think that is the message. So you see someone who ended up in the psychiatric ward in Europe comes and meets a physician in a third world country, and then they get a solution to their problem. So if anything, I think this should encourage us and motivate us that all we need to do is do our best, do the reading, practice, and then pay attention. You will help a lot of patients maybe and save them a lot of money. And then lastly, thank you, Joseph, for the case because it taught me a lot. I think it has exposed a lot of my knowledge gaps, which I have to go and cover, and then reminded us some things that I think we all benefit from, and we'll go and read more and maybe help more patients. So thank you very much. I think I saw Moshi raising a hand at some point. Please welcome if you have anything. So before we close, anyone I see, and thank you very much, everyone. The chat is getting busier by day. So Moshi, if you have anything, please welcome and share your thoughts.
Okay, good evening, everyone. Thank you, Dr. Joseph, for sharing this case. But I was wondering from the history because we missed the stack effect because from the MRI the tumor was more on the pituitary sac. So if you have a tumor on the pituitary sac, we anticipated this patient to present with those features of libido erectile dysfunction. Sometime might present with features of hypopituitarism. Maybe we missed it from the history, and also the important part to this patient to investigate on the prolactin. So as we can see, because there is an like positive feedback, because when you have an pituitary tumor or complexing the pituitary sac, mean you impair the dopamines, which will lead more production of prolactin hormones. So I think we missed that part, or I missed it from the history.
Yeah, thank you, Moshe. I think you are right. I didn't ask about the libido. I didn't do the hormones. Yes, which are well indicated. I believe in that. But yeah, there are things that were going on, and once I got the MRI and those this said, why pursue other things? But that's true. Maybe I could have foreseen it and do hormones or ask about those questions about libido. You are very right. But something else, I think, David, that you raised, I also can't explain why the ESR is high, but in AfroDX, we present real patients. This is real life. This is how you see. You send a test, come back. I can't explain it. I tried to Google around seeing if this tumor is rated nothing. Maybe I thought maybe the blood is so heavy, doesn't have water because of the DI, but still, again, nothing. So I just throw it away. It doesn't help as anything, but we have the solution. The patient has to go for surgery. Hyponatremia, if you have DI, you pee a lot, but you'll be peeing solute-free water. So we don't expect hyponatremia. And even hypernatremia also, we don't expect it unless patient has impaired thirst centers. They don't feel thirst, so they can't drink water to collect their own hypernatremia, or they can't access water, like patient is unconscious, they're in ICU. I've seen one. And again, they are very young, like the kids, neonates who are just lying and no one is there maybe to give water, or the very old, they have maybe maybe neurodegenerative diseases, Alzheimer, they forget to drink water. But otherwise, if you have intact thirst centers, no matter how much you pee, you won't get hypernatremia because you'll be correcting it yourself. That's why you have the thirst. Yeah.
Thank you, Joseph, and thank you, Petro, for the good inputs. So before we close, because we exactly at the hour. So if anyone else has anything, if you have any experiences to share, any questions, anything before we close, please welcome. I do not see any hands. So the same call. So Joseph, I received a call, a very encouraging call this week. Someone is preparing a case that he will share with us here. So it's still in preparation. We'll see the case. So I think that will be an interesting one because it's not presented for just for it's the final diagnosis has not been reached. So basically, it's presented here for us to brainstorm and figure out the final diagnosis. So when the time comes, we'll share that case here. So that should encourage everyone else. The interesting cases that you see that will learn something from, please bring them so we can learn, and then discuss, and so also come forward and discuss so we can learn from you. So having said that, if there's nothing else, it was good. Yeah, so Lugino has something. If you are in a place where you can unmute, can you? Yeah, so he's saying the only diagnostic here, the only diagnostic test here was MRI. However, it was difficult to decide for it. That is why at Europe they did not reach that decision. Yeah, so we are not sure really what transpired there, but maybe we could say that maybe the presentation was an early presentation and they just thought that this is a psychiatric illness, and that is why they ended up there. But then spending time and taking history, we see what it has uncovered. So I think this is an interesting thing that we've seen, that reminds us that a good history goes a long way to help patients, because if you spend time with the patient in order to decide that this patient needs an MRI or not, it's because of a history. So I think it reinforces one thing, that we need to pay attention. So thank you very much. So if there is nothing else, have a good night and see you next weekend.
Good night.